Empezamos con el primer tema, que es hernia post-bypass gástrico a cargo del doctor Fernando de Barros de Brasil.
A los 3 minutos que después de terminar su exposición, doctor, se le va a pasar la voz para que pueda acelerar su exposición. Ok,
tenemos contómetro, el cronómetro inverso también.
Ah, ok, gracias.
Good morning, everyone. My name is Fernando de Barros. I'm from Brazil, Rio de Janeiro. This video is about a very common situation in bariatric surgery, a situation that unfortunately is missed frequently. This is Peterson's hernia. So, this video is about a female patient, 39 years old, with a BMI of 45, with diabetes and hypertension. She was submitted a laparoscopic gastric bypass in 2010, and after 2 years she came at me with chronic abdominal pain, and after a CT scan shows a total looping of the mesenterium, I decided to do a laparoscopic approach. So, at the first month, as you can see here, I'm a little bit lost, I don't know what's going on, so I decided to cut off the knob, probably was done by the other team, and started first pull the alimentary limb to the right side, but it didn't work, as we can saw, and after that, I keep pulling to the left side of the patient. But suddenly it stopped. And as we can see here, there are a lot of adhesion just next to the intraarterial anastomosis. So I decided to cut it off with using the hook with a monopolar energy. And at this point in surgery, I can't understand if the hernia goes to the right side from the left side of the patient, or is going to the left from the right side. So I release it, and now I'm pulling the pediopancreatic limb to the left side of the patient. And I'll pull it until getting the duodenum that we will see just below the alimentary limb, just down here. But as we can see, there are a lot of small bowels from the other side. So I decided to go to the other side to check what's going on, and we see here a total twist of the mesenterium. And for my surprise, there was no necrosis of any part of the bowel. And there are a lot of commoning and a lot of mesenterium that probably is pushing the hernia down, and I couldn't reduce it from the left side. So my strategy was to put all the bowel up to the liver and put the patient in Trendelenburg position. Now, I'm sure that this is a big hernia and it's coming from the left to the right side. And we will see here the twist again. So this is my goal, put all the bowel back to the left side. So after do this, I started all again, pulling the alimentary limb. The alimentary limb was about 1 meter. The ateroenteral anastomosis, and then the pediopancreatic limb until the duodenum again. The pediopancreatic limb was about 1 meter as well. This patient, and nowadays she doesn't have hypertension anymore, and she's not diabetes anymore, and she lost about 30-35 kilograms. Now I'm getting in the duodenum, and at this point, from this view, we will see how big is the defect just below the alimentary limb. Here you go. You see all the mesenterium crossing the defect just below here. And I go below the alimentary limb, and catch the column that I put up in the liver. Here you go. And now I can reduce it easier. In a few next minutes, we will see a lot of power reduction here. So, Peterson's hernia was first described in 1900 by a German surgeon called Dr. Walter Peterson. She first described 2 cases of internal hernia after gastrojejunostomy. So, every patient who was submitted a gastrojejunostomy can develop this kind of hernia. But you gotta remember that our patients, bariatric patients, we lost a lot of weight. So, small defect can get bigger and bigger while patient lost weight. And probably a laparoscopic approach has a higher risk of this hernia, because when you do an open gastric bypass, we see a lot of lesions after the surgery. So, and when you go to the papers, we see an incidence of Peterson's hernia range from 1.5 to 9.6%. But we are missing this diagnosis, and probably this real incidence is more than 10%. And it seems that when we close the defect, we have a lower chance to have this kind of hernia. But we have to remember that when we close the defect, it can be complained about some complications as hematoma and ischemic problems. Well, I'd like to apologize about the end of the surgery, because I don't know what happened, but my device just shut it down in the end. But as you can see, there are a lot of ball into the hernia, and I guarantee that's almost the end of the surgery. Anyway, I'd like to show how I've been close to the defect. I started always going down in the mesentery of the alimentary limb, just here. Then I go back up in the mesocolon. And once again, back in the mesentery of the alimentary limb, and finished with just one knot. As we can see, my assistant up here is pushing the column up, so I can see the defect. And while I'm tying the knot, he will take the column down, and it turns my job easier. Here we go. It's closed. Well, this is my hospital, Andaraí Federal Hospital. This is our operation room in Brazil. And this is my team. And I'd like to thank all members of my team for the support in the last years. Thank you very much.